Hi, I'm Dr. Martin Rutherford, certified functional medicine practitioner, chiropractor since 1979.
Dr. Randall Gates, board certified chiropractic neurologist, as well as being a chiropractor.
We're here discussing many different topics. Today is going to be food addiction. Do you have it? And it's an interesting topic for us. Everything that we talk about here flows from maybe things we have seen in practice that we think are consistently we see consistently enough to share with you to know that if you follow through on what we told you, you would probably get some good results. But we also learn from things that we're having difficulty with. And our goals here, our practice has morphed into putting the brain work together with the metabolic work and inadvertently developing a chronic pain practice. And a big part of getting chronic pain down, as most people seem to be aware of today, is diet. Okay, a lot of people come in and they say, I've tried this diet and I've tried that diet and I've tried this diet and I've tried this diet, and it worked for a little while and then it didn't work, and that's another whole subject, but there's a reason for that. But diet properly evaluated and diet properly, there's no one diet out there for people who have chronic problems, just for the record. But to get to that one diet and to figure it out precisely for that patient is hugely important. And it's anywhere from probably 30 to 40 to 50% of that patient getting better. Once a person gets through our program, specifically, diet now becomes a substantial portion of them getting, who knows, staying better, maybe 90, 95%, maybe in some cases 100%. But that's where, as you have fixed everything else that has caused somebody to be sick or have a bad gut or have a bad immune system or have a bad overfiring stress mechanism or something like that, after you've calmed all that down and gotten all that handled, now diet is where it's at as far as you staying better. Well, our goal is to have our patients stay better. If you are a patient of ours, you get a little tweet from us or whatever day it is.
Yeah, every week.
Every week. Maybe we'll do one this week on the Super Bowl. and it's dangerous, which is going to tie into what we're going to talk about here today. But the biggest challenge that we're having is to have our patients stay well is for them to follow their diet.
Exactly.
And Dr. Gates has expressed a little frustration with it, because it's not that we're frustrated because people can't follow the diet, because we kind of understand why, and we're going to talk about it right now. But we're frustrated because we try to give people the tools so that they can stay better once they're done. And this is kind of semi out of our hands once it's out, other than us coaching them and saying, don't do that, and so on and so forth. So we're going to talk about food addiction. Is it real? I don't know if that's even an argument at this point in time, but it is. And do you have it? And if you have it, and I do, I have celiac. I have celiac, the gluten thing. And I mean, I'm telling you, I see a nice bread sitting there, or hot bread, and when you go out to dinner, or a pizza, a real pizza, and stuff like that. It's like, man, it's like, I want that. I really want that. So we're going to talk about that today. So, overview of the problem of food addiction in general. Why don't you take?
So this is a societal problem. 2/3 of us basically have a weight issue. 1/3 of the population is overweight, 1/3 of the population is obese. I've said it in other broadcasts, I'll say it again. By 2050, it's anticipated that 2/3 of the American population will be clinically obese, 1/3 of the American population will be diabetic. We have a problem with resisting food. And anybody who disputes food addiction, I think they just need to look at the problem as a whole. They also need to look at the current literature that's coming out that's pretty dang powerful, showing how food addiction is incredibly similar to a cocaine addiction, an alcohol addiction, to a morphine addiction or a heroin addiction. It's the same biochemistry that's happening. And so we need to approach this problem head on, and I don't think it's really being done. So that's kind of the global scale. Also, it's a worldwide problem. We're now seeing that, most industrialized countries as well as developing countries, we're seeing the same thing. People are getting bigger
Mm-hmm.
They're gaining more weight as compared to like 100 years ago.
More chronic problems. Used to be more here, but not anymore.
Yeah, now diabetes is a huge problem in China, for example, whereas 20 years ago, it wasn't a big deal. And then we have our patients, as Dr. Rutherford said. We have done 26 weeks now of little 5-minute video clips to our patients, specifically on the topic of food, how to stay on their diet, little tips for staying healthy. And continually, we're still hearing the same stories. Even though we've done 26 weeks and we're sending this out by email to all of our patients, we're still hearing about Johnny, who went off the diet and now the neuropathy is back, or Susie, who is now eating gluten and all of her thyroid symptoms are back. And it's semi-frustrating. In one sense, you know, you feel like you're banging your head up against the wall. By the other sense, you have to say, okay, well, what we're doing is a good effort and it's coming from a really good place. We've had a number of patients express that to us, where they say, thank you so much for these weekly videos. It really shows that you guys care and you want me to stay better. And we do, more than anything. By the same token, we still have a lot of patients out there who are just not succeeding with their diet. And
but
because of that,
so I mean,
well, and that's where I'm going.
Yeah.
And so because of that, they're not succeeding. They're not succeeding for a reason. It's because of their brain biochemistry is so much like a cocaine addict or a heroin addict. And that's what we're going to go into today. And we'll talk about solutions for this. We'll also talk about relative to food, how fat mass in your gut or in your hips can interact with this whole problem.
Yeah, and it's really important. It's just like Dr. Gates said. I hear it regularly. One of the first questions I ask people, we don't recommend treatment to everybody who walks in the door. And we try to evaluate a person to determine whether they're kind of like, I think in Alcoholics Anonymous, they say you have to hit bottom, whether they've kind of hit bottom and they're ready to do what they need to do, which mainly we're talking about the dietary changes. Our patients don't need to go to the gym. They don't need to do all that stuff to get better, but they do need to make dietary changes. And when we first started, before you got here, and when I first started doing dietary stuff, we didn't know a lot of stuff we had, and we didn't have all these things. I would say to the patient, I want you to write down your 5 most favorite foods in the whole world. This was part of my evaluative procedure. And they'd write it down. Sometimes I wouldn't even look at it, but I'd look at it. Sometimes I wouldn't look at it, and I'd hand it back to them and I'd say, so what if I told you can't eat those for the next 3 months? And I would watch their reactions. If they started getting like a head jerk or something like that, or their eyes started twitching, or, you know, you could tell they were like, I'd say that wasn't what I was looking for, because I'm going to guarantee you the foods you're sensitive to are going to be the ones that you absolutely love the most. But it is an addiction. And as Dr. Gates said, it was like trying to tell people not to take cocaine, or that's what we're starting to understand. It's like telling people not to drink alcohol who are alcoholics and things of that nature. And so, it's really interesting. Our nature is to delve into these things, though, once we get to the point where we say, okay, this is a problem. Our goal is for folks to stay better. So we're going to give you a little bit of that data today as to where it's going. As you said before the forecast, before the broadcast, we don't have all the answers for sure, but we need to come up with something. You know, we did have we can talk about it. We used to have a gluten, remember we used to have our gluten support group. Right.
And we had a wonderful patient who watches these broadcasts who would take her Saturday morning. I mean, can you imagine? I mean, we talk about,
and people we
meet every Saturday morning for a business meeting, but this patient would take her Saturday morning, drive like 45 minutes to get here, set up food, she'd bring food, and nobody would show up. It was like,
because I don't think people understand how serious this is. So you're going to know how serious this is. Look at some of our broadcasts on gluten sensitivity. So
and thank you to that patient.
Yeah, if you're watching,
really appreciate it.
Yeah, that was great, and
it was a huge part of our development.
Yeah, so addiction. Let's talk about food addictions in general. Why do people get addicted to these foods?
They get addicted because basically when you eat these foods, they cause a release of dopamine in the brain, and they may be associated with morphine-like chemicals. What that means is that a surge of dopamine is a neurotransmitter, it's a neurochemical in our brain. And when you get a release of dopamine in your brain, in this one area, it's kind of like a pleasure center, then you feel this massive reward in your brain. And it can become really pleasurable, and it becomes addicting for some people. Now, depending on what the stimulus is, for some, the stimulus is methamphetamines, some it's cocaine, others it's alcohol, others it's heroin, or it may be prescription pain medications, oxycodone, or it may be alcohol. In this case, it can be food. So it depends on whatever the substance is. And they've done so many really interesting studies on animals and humans where, they may take like a monkey and they can put a little probe into the monkey's brain right where the pleasure center is. And the monkey will disregard eating. It will disregard any basically bodily function except to keep pressing a lever to get the hit of dopamine in its brain. So dopamine is very, very powerful for our behavior.
Yeah, and gluten has a specific aspect to it.
Exactly.
Gluten actually has 25 different, it's more than 20, no, it's how many different aspects of the gluten?
Oh, there's a ton.
Let's say 25, okay, and 25 different aspects. For those of you, gluten, you got your blood test, they told you were okay. That blood test tests one of like the 25 different aspects of the gluten protein that you need to test to find out if you're allergic to it, which is why it's so inconsistent and unreliable. But that one aspect of it is called
gluteomorphine.
Gluteomorphine. Your gluten has something in it called a gluteomorphine proteome.
Exactly. So basically it forms a heroin-like chemical. For some people, when they eat gluten, they get a morphine-like chemical in their brain. And so it becomes addicting to where when they see bread or they see pasta, they want to eat it because it's like a morphine fix in their brain, believe it or not. So within the dopamine addiction, so now you understand that when an alcoholic drinks alcohol, they get a hit of dopamine. When the cocaine addict hits the cocaine, they get a hit of dopamine. Well, above that area of the brain and the reward center, there's another area. It's right kind of between our eyes is a good way to think of it. And it's called the ventromedial frontal lobe. And this is the area of our brain where we evaluate risk versus reward. And so people who have strokes here, they may know that something is wrong and they may be really good people, but then they'll just go and do really kind of what we would consider not smart things to do. And they may commit crimes and they just say, I don't know, I just couldn't control myself. There's a big argument right now that this may be occurring with some people who have incurred multiple head injuries through different sporting activities, but we won't get into that. And so when you can't control your impulses or the risk versus reward battle in your brain is not able to overcome the addictive urge, then you find yourself, taking cocaine repeatedly or methamphetamines, so on and so forth, or you're binging for some types of food all the time. And this is just incredibly interesting because the definition of addiction is that people basically keep going to these substances even though they know the negative consequences, which really turned on a light bulb for me because we just had a patient. I'm going to kind of scramble it so I don't get a negative email about this. Let's say we have a patient with fibromyalgia and they get discharged from the program. They give us a glowing testimonial about how well they're doing, how well he's doing. And then we later find out that this person is eating foods off of their diet and all of a sudden their fibromyalgia symptoms are back. And they know it, but they keep eating these foods. That's addiction. That's a problem. And I'm not necessarily saying that this individual fulfills the Yale food addiction scale, but I think anybody watching this broadcast can realize you're on a diet, you're feeling great. Now you're knowingly eating foods off of your diet, even though it's maybe 3 times a week and your symptoms are coming back and you're still doing it.
Yeah, it's the person who has COPD and is still smoking.
Still smoking.
Yeah, it's the same thing, and it really has just come home to us lately. And one of the things we've been able to, well, one of the things we've been able to observe over a period of time, what is it that actually causes chronic pain? And 2 of the main factors that we see consistently in our chronic pain patients, I don't care what they come in with, I don't care if they come in with a chronic pain in the right big toe. The 2 factors that seem to be consistent are they usually have an immune problem and they usually have chronic stress.
Yes, exactly.
And stress hormones can play a
huge addiction,
huge factor in you continuing to need to eat these foods. And as you watch every one, I've got this, trust me. This is it's so hard not to eat the things that I am allergic to. It really is.
And what happens is, for example, with like an alcohol addiction, when If you're not an alcoholic and you drink alcohol, actually you can get a spike in your stress hormones. It can actually be more stressful to your body. Whereas for an alcoholic, their stress hormones are typically circulating at a high level, and when they drink, then their stress hormone levels go down. So it's very calming to their brain. We're finding the same thing applies even to food addiction. So people typically who have food addiction, maybe they have high stress jobs, they've had stress in childhood, they're under a lot of stress. Frankly, this is a large percentage of the American population. A huge percentage of the American population has anxiety to begin with. Then we add on to that group childhood trauma, then we add on to that group just people who are stressed out of their minds and their careers, and they have a lot going on. They have kids, they're not eating correctly. So a big percentage of our population, which maybe is why 2/3 of the American population has a weight problem. And so then they go to foods to eat those foods, and it actually calms down their stress hormones momentarily. Very similar to any other addiction. And so it becomes, a stress relieving problem for them. Although comfort food, although in the long term, it has very negative consequences.
Yeah,
obviously.
And the top comfort foods are
gluten,
pizza, pasta, bread. They do an annual survey of the world. I don't know who they interview exactly, but the top 3 last year were pizza, bread, and pasta. Those are the top 3 comfort foods that people went to. Mm-hmm. But in general, it's going to be some sort of carbohydrate, and frequently it's going to be gluten. Yeah. And this is not the gluten show, okay? But it just happens to be that this is something that is the biggest, most difficult challenge for our patients. And so that's why we're sharing it with you. So other than knuckling it out, mm-hmm. other than hanging on, other than going to gluten or food allergy addiction anonymous, which wouldn't be a bad idea, frankly, to have. I think maybe they have that, don't they? Would that be like Weight Watchers and all that? Like,
I don't know. No. I haven't heard of it.
If there isn't one, there probably should be one.
Somebody told me I should start Workaholics Anonymous, but then I said, well, no one would show up because they're all working.
There you go. There you go. There you go. All right. So that was our effort at comedy there.
Yeah, exactly. So in terms of solutions, and I want to tie in leptin. So the other problem with food addiction is that once you get addicted to food and you get in the cycle, then you have a tendency to put on more body mass. Typically it's fat. And then that fat becomes an organ unto itself that creates hormones. It secretes hormones. It secretes chemicals that then cause you to basically continually crave more and more food. So the food addiction gets worse. One is called leptin. So leptin is in our body to help us know when we're full, when to stop eating. And we can become leptin resistant when we become overweight. So just like people become insulin resistant when they're overweight, we become resistant to this chemical called leptin, which tells our brain when we're full, so we keep eating. There's one argument that artificial sweeteners can do the same thing. It's a contentious argument because that's a big industry, but there is data to cite that as well. So solutions come down to your neurochemistry, solutions come down to your stress hormones in our experience. And that's what we're trying to delve into. We're not saying that we have the definitive answer. We're trying to figure it out right now because this is a problem that needs to be fixed. And we can take a patient through our program and be very successful who can't lose weight and all of a sudden they've lost weight, or they had diabetes, and we can get the diabetes reduced significantly. But now the question becomes, how do we maintain it? And we have been doing everything we can to help our patients maintain it, from gluten support groups to our weekly broadcast, which we're going to keep doing. But possibly some people just need more neurotransmitter support in their brain. Possibly we need to continue adrenal gland treatments with our patients because their stress hormones may still be high, and that's why they're fiending. The other thing is that it's talked about in the addiction literature is like cueing. So we can become conditioned. So if every time Dr. Rutherford walks past my office, he says, "Hi, how you doing?" Well, if he walks by one day, I'm going to say, "Hi, how you doing?" back, and he may not say hi. Well, I become conditioned to that response. Addicts become conditioned when they smell cocaine to want cocaine, or if they see maybe someone who looks like a drug dealer, that makes them want to consume whatever the drug was. The issue with addicts is that they can kind of segregate themselves from that echelon or that part of our society, so to speak. Mm-hmm. You know, an alcoholic can avoid going
There's
to
a
the
lot of
beers.
social pressures.
However, with food, it's completely different because everything we do is based around breaking bread, as one patient put it to me, which is so true. Or the holidays, or the Super Bowl, as we're going to talk about today to our patients. Everything is based around food. So there's this continual cueing that you have going on when you're trying to maintain your diet. And it is so difficult, especially when your dopamine center in your brain has been used to being pushed every time you reach for a piece of sourdough bread. I get it. And then your risk versus reward center of your brain above the dopamine area is trying to say, no, don't reach for it, don't reach for it. But sometimes it's just too much because you're continually surrounded and put into the wrong situation.
Yeah, and it gets pretty hairy sometimes. I mean, people get almost religious about their food in a sense of if you're sitting there with somebody. I know I've been in this experience where I've been sitting there with 6 other friends, and my wife and I were the only 2 that weren't eating. I'm also a vegetarian. So I'm a vegetarian who's off gluten, right? And I'm sitting there eating with everybody's eating normal meal. I'm not saying anything. They're eating their chicken, they're eating their beef. That's fine. I have no problem with that. They're eating their gluten, they're shoving the bread down. That's fine. No problem with that. I get a salad. I get a glass of soda water. And the next thing you know, I'm attacked. I mean, I'm like not saying anything. I'm not making anybody feel bad. It doesn't matter to me. They're not my patients. They're acquaintances. And I could see where it's really easy to go, God, you know, please order me a pizza so I can just shut everybody up here. Will you please? In addition to the fact that you'd love to have one on top of it.
Yeah, exactly.
So it's really it really is a dilemma that we're not joking about, because our goal truly is, see, a lot of folks who have chronic pain go to practitioners in general, and there's so many people out there and there's so much noise out there today as to come to me and I'll take care of your fibromyalgia, and come to me and it's candida and it's this and it's that, and you go and maybe you go for treatment for a month or 2 or 3 or 4, and then finally at the end of like 10 or 12 months you figure out this is going nowhere fast. And so people already have that concept of when they have chronic problems that this is going to be an open-ended thing. I had almost a mini attack on me yesterday from a gentleman who came in to consult me to see if I could help his wife. It ended up really well. But you have that concept, and now you come to us and we go, wow, we can get you probably handled, depending on what we find, in 3, 4.5, 6, 7 months, 9 months, something like that. And we can. But our goal is to have that person better and stay better and give them all the tools to get better. And we give them all the tools to get better. But this one tool is one that's getting away from us. And we're trying to figure out, how do we help these folks to not do this? Because otherwise they're going to keep there is a way to get out of the chronic pain, but now the way to stay out of the chronic pain is kind of out of our hands, unless we put like a coaching program together for like the rest of our lives. Then we'd be sitting here all day long, once a month, saying, did you eat anything this month or whatever? I don't know. And if you have any suggestions, trust me, we're open for it. But it really is almost like, I'm not joking, it really is almost like you should have a food addiction anonymous or something like that. It doesn't have to be a food addiction anonymous, but some support group where people can draw strength from each other, draw understanding from each other, even allow each other to realize they're not crazy. A lot of these folks who are putting the social pressure on the people to eat have the same food sensitivities and same bad habits, if not worse. And it makes them uncomfortable that you're sitting there and you're eating properly and you're following a good program and you're healthy. And so they start making fun of you. And a lot of people can't withstand that. There's controversy about gluten. I mean, there are other food sensitivities. We just use gluten because that seems to be the one that sabotages our patients the most. And so, it is a comprehensive issue.
It's a huge problem
that we're looking for. But Dr. Gates has been talking about maybe some specific things, and is talking about maybe some specific things that we can do. We try to treat our patients with the least amount of supplements, the least amount of herbs and botanicals that we can. Frankly, we find that that's better. And we give them exercises to do when they're done, so that they can have stress modification exercises and protocols, and things that I'm told are really effective by the patients. They stop me and they tell me how effective it is. But then once you get off of that diet and once you start into that other area, then it kind of sabotages everything. It's pretty mind-boggling, but it does. And then we have patients coming back, and it's you know, it's a challenge.
It's a huge challenge. It's a huge challenge. Yeah. So that's where we're looking at instituting. Everybody who's watching, you can go Google Yale Food Addiction Scale. We're going to start using this with our patients before and after our treatment. I'm even thinking we're going to make it mandatory that patients have to fill this out one time a month, even after we're not seeing them, just so we can see, okay, are you starting to slip? You got to get back in here so we can talk. Because I've found some patients who have no ability to control their impulses with food while they're going through the program. And we will put them on specific neurotransmitter support, lots of times dopamine-like supplementation. And we've had great results with it. And some of the current literature relative to addiction specific to drugs is talk about using basically dopamine medications to help these people. Other medications that are being used are morphine blocking medications. So you just don't get the same hit from taking morphine. Or when you use, a prescription pain med, it's not going to help you as much. Well, morphine is involved in the food addiction process as well. So I'm not saying we're going to send our patients for that, but I'm just saying these are things that we're thinking about in terms of natural supplementation strategies to help people who just can't control their impulses. And it's not as though they're bad people. They're not. We both have dealt with it. I was 60 pounds heavier a couple of years ago because I had a food addiction. And it's still something that, I think all of us struggle with, but are you winning the war or are you losing the war? And if you're losing the war, that's what we want to know in terms of our patients so we can better help them to maintain their successful results. That's the bottom line. That's the whole reason that we're doing this. And that's the whole reason that we spent a lot of time in the last week researching this, looking at it. It is a problem. People will make fun of the other addictions. I mean, even there's still stigma about alcohol being an addiction. Alcohol is definitely an addiction. But the whole Tiger Woods thing, people were laughing about the sex addiction thing. Even our favorite satirical comedy did a great episode on it. And it's funny, you can make fun of it. Relative to food, we got a problem, people. We have a huge problem as a society when 2/3 of the nation has a weight problem. And it's only getting worse.
And half of the adult population has chronic pain.
Yeah, and we're finding that a lot of those chronic pain conditions are tied to the gut and the foods that we consume. So food is a big deal. It needs to be talked about. Maybe we do need to start a Food Anonymous, Food Addict Anonymous.
We need to do something.
Yeah. So that's where it's at right now. Anything else you want to interject?
No, I think that pretty much covers it.
Okay.
Any suggestions? we're open for. I think we'll be able to handle it in some ways. That we're kind of reticent again to try to. We're always trying to do it with the least, as we say, the least amount of intervention. The more we can let a patient go with a basic diet, maybe some stress modification program, exercises or strategies to handle their stress hormones. The more we can do that, the less we can do supplements. That's kind of been our mantra, but we might have to give some here relative to some supplementation. Yeah. Or we've been trying to do it so that patients don't have to keep coming in forever, so that they don't have to go on a maintenance program. But we may have to just up front say, hey, this is where it's at. If you can do this, then you'll be fine. But if you really find it hard sticking to this diet, we may have to see you once in a while and just kind of stay on top of it and things of that nature. But we're just trying to bring the realities out there of what's going on. We did another program not long ago. There's no silver bullet for the chronic pain patient. And we can do pretty good at getting chronic pain patients out of pain or improving them substantially in most cases. And now we're kind of looking at the aftermath of like, okay, let's keep them better. Okay, and that's where this is at. So anyway, I hope this is something that was interesting to you. Let us know. We'll try to come up with something. Seems like our practice just keeps coming up with these things for us. So we'll probably come up with something interesting again next week. And we're getting a lot of positive feedback on this. We really appreciate it. If we weren't getting positive feedback, we wouldn't be doing this going on 2 years now, or a little over 2 years. And so thank you for the positive feedback. If you need to see any of your other videos, that's at powerhealthtalk.com. Yep. Scroll down to Hangouts, pop, and there's 200 hours worth of videos on there on basically everything you could ever want to know about chronic pain and chronic issues and gut problems and stuff like that. So, so that's it. So we'll see you next week.